All right, hello everybody, we'll get started. Thank you for attending our Digital Scholars webinar here today. I know this is the first week back for a lot of people from break, so I really appreciate you attending. This is hosted by the Southern California Clinical and Translational Science Institute, the University of Southern California, and the Children's Hospital, LA. So my name is Eric Peterson. I'm the co-director of digital recruitment and scholarship within the Southern California CTSI. I'm also an associate professor of psychiatry and behavioral sciences here at USC. Please, for today, if you can add questions to the chat at the bottom of the webinar panel. The speakers today encourage active participation during the talk. I know a lot of times we save our Q&A for the end, but our speakers today would really appreciate comments as they come in. You can have an active discussion either in the Q&A section or in the chat feature of Zoom. So please feel free to type in your questions as they come up throughout the talk. We'll also have some time at the end to field some questions as well. So we're excited today to host two speakers. We have Dr. Pamela Sinekroop and Zoe Merritt. They'll be talking to us today about how social media can be used as a platform to help initiate health behavior change. And they'll be talking in detail about some lessons that they learned while conducting the Can Quit study with Alaska Native cigarette smokers. So please allow me to introduce Dr. Pamela Sinekroop. She's an assistant professor of psychology at the Mayo Clinic, and she's a member of their behavioral health research program there. She has a doctorate in public health. Her research work focuses on reducing morbidity and mortality related to cancer and chronic illness, and she has much expertise in health behavior change, social media, health intervention, and mixed methods research. She is a co-investigator on the Can Quit study, which is the focus of today's talk. And I'd also like to introduce Zoe Merritt, who served as a moderator for the Can Quit Studies Facebook group. She's a senior research associate with the Research Services Department at the Alaska Native Tribal Health Consortium in Alaska. And Zoe has an MBA in general management. She's currently enrolled in the Indigenous Studies PhD program at the University of Alaska Fairbanks. And her particular expertise is in tobacco cessation treatment counseling. So join me in welcoming our speakers today, and I will hand the program over to them now.
So hi, everyone. I'm excited to be here the first week after the holiday break. And Zoe and I are going to take turns giving the presentation. So Zoe, if you want to go ahead and kick it off, and I will watch the slides for you.
Okay. Good afternoon, everyone. I hope everyone's having a wonderful start to 2022. And today we're going to be talking about using social media as a platform for health behavior change. And this is based on our experience with the development of the Can Quit study, which stands for Connecting Alaska Native People to Quit Smoking. And so today we'll be giving an overview of why social media is an effective platform for promoting health behavior change, the process for developing the Can Quit study and what we learned from this process. And we'll also have time for discussion and questions. So I just want to reiterate that we really encourage your participation. Feel free to comment in the chat box or post your questions. And also feel free to introduce yourself and where you're at right now and what was the most fun thing you did during the holiday break. I could share the most fun activity I participated in was probably ice fishing. Right now in Alaska, it's -5 degrees though, so I'm kind of stuck inside, but it was really nice to get outdoors during the break. So why social media? It's widely adopted. I'd be really surprised if people on this call don't have a Facebook, a Twitter, an Instagram. It's very commonly used across Alaska, across the country. And this allows us to overcome barriers due to geography, weather, which could be like traveling into remote communities. And it's also effective during the pandemic where we can't meet face-to-face. And this allows us to increase access and engagement to underserved, diverse populations that live in remote areas. And it's an easy way to share evidence-based resources, regardless of where you're located. And it also provides a platform to provide peer support. And it's also cost effective. It's essentially free for people to sign up for a Facebook account. And it provides a platform to increase your recruitment options and to recruit people from across the state in Alaska's instance. So there are some concerns with using social media. One is privacy. Everything you post online has an audience, and so there are concerns over people's privacy. You have to have some amount of digital literacy, like you need to be able to know how to use a social media account and create a social media account. There's also concerns around access. There are some areas that don't have reliable internet connections. Not everyone has access to a computer or tablet or cell phone. And there's also concerns over the face-to-face connection being lost. And when creating a social media group, you need to have good moderators that have the skills to create community and foster communication between group members, and also to have the background knowledge on health behavior change and the content that you're presenting. So what is your experience with using social media for work? And what are your concerns and challenges for using social media? So the Can Quit study was built off a 20-year partnership between the Alaska Native Tribal Health Consortium and the Mayo Clinic. It built off of previous research, tobacco cessation research conducted in Alaska. And this map shows how big Alaska is. And a large majority of the communities aren't connected to the road system, and you have to fly by airplane or a bush plane to get to the community. And so Alaska Native people experience significant health disparities because they're difficult to reach and they have limited resources. And an Alaska Native value is like family, community, and connection, which makes social media a feasible platform to use to deliver health interventions. And I just wanted to briefly mention our research team. We have staff from the Alaska Native Tribal Health Consortium, the Mayo Clinic, Mayo Clinic Connect, Stanford University, and the University of Michigan that collaborated on this project. And this project was funded by the National Institute of Health. So we chose to conduct the Can Quit study because Alaska Native adults reported that they had a higher smoking rate in comparison to non-Native Alaskan adults. In 2017, 37% of Alaska Native adults reported they smoke in comparison to 17% of non-Native Alaskan adults.
Okay, so I just wanted to give you guys an overview of what the Can Quit study was. So we had this partnership. We have a problem that we're trying to address. And so our goal for the study was to develop a scalable and sustainable intervention to promote use of existing evidence-based resources for tobacco cessation. When I say evidence-based, I mean there are plenty of type interventions and programs available that have been shown through research to be effective at improving people's chances of quitting. But one of the challenges for, say, the quit lines or tribal quitting programs is that they don't reach the intended audience all the time. So utilization is suboptimal. So we wanted to say, how can we connect Alaska Native people to these resources? The framework that we use for developing an intervention to use social media as a way of increasing utilization of evidence-based resources and support was using a community-based participatory research approach. So we spent several years developing the research idea. We presented it to multiple advisory boards for feedback. and ideas, and slowly drafted a proposal that represented the needs of the community. An additional interest, not only for Alaska Native people, was that ANTHC also wanted to be able to figure out ways that they could help to promote utilization of these resources. So the eventual goal would be, if we could develop something that was effective, then that this program or social media group could be taken over by ANTHC as a regular program. As I mentioned kind of earlier, the resources that we focused on were the Alaska Quit Line and the tribal quitting resources. And we wanted to promote them using existing content that would be adapted from the CDC TIPS campaign, which was already shown to be effective, and also from digital stories created by ANTHC. They have a digital library of digital stories, and storytelling fits with Alaska Native culture. So again, these are the evidence-based resources. The one I did not mention was smokefree.gov, and smokefree.gov is the resource that we provided to both our treatment and control group when we were for the pilot randomized controlled trial portion of this study, which we're not going to discuss today. So for this study, we wanted to recruit both Alaska Native people and stakeholders and Alaska Native people who smoke, which would be tobacco cessation counselors. But for the Alaska Native people who smoke, to be eligible to participate in phases of our study for both developing the Can Quit prototype and for participating in the pilot randomized controlled trial of the intervention. Alaska Native men and women were eligible. They had to be adults, smoking more than one cigarette per day over the past 7 days, with cigarettes as the main tobacco product used. There are other, tobacco products that are prevalent in Alaska, like ICMIC or chews. A person has to be considering or willing to make a quit attempt, have access to broadband internet with a Facebook account, or be willing to set one up, and then not currently enrolled in cessation. So willing to make a quit attempt, but not actively quitting. To recruit for our study, we used primarily Facebook. So we used Facebook ads, and we had a lot of activity on that. And I have an example of what the Facebook ad looked like. And interestingly, we had a lot of response to our ads. You can kind of see below, there's over 200 comments on this one ad, and we had multiple ads going to recruit for the different phases of the Can Quit study. So this figure here is an overview of the whole study. And for this talk today, we're talking about phases 2A, 2B, and 3. And those 3 phases are the phases that we used to develop the Facebook group prototype. And by prototype, I mean the Facebook group itself, the content library, and the moderator training. And you can see phase 1 is qualitative. So we started out actually, let me back up a little bit. We started out by selecting this existing content from ANTHC Digital Library and from the CDC TIPS Library. And what we wanted to do was take this good content and present it to Alaska Native people who smoke and get their feedback on whether or not they were responding to it, if they thought it would be effective, and whether or not it fit with their culture. And so that was the first phase. The second phase, we showed some content to another group of Alaska Native smokers. Each group is mutually exclusive as far as participation, and where they would look at the content and fill out a survey of perceived effectiveness. And then the next phase is where we actually develop the prototype. And then the final phase that we'll discuss is where we beta test the prototype for a month. Okay, so I see that there's no one chatting. So I don't know if you guys are not familiar with this, but please just feel free if you have any questions. I'd love to get a feel for our audience. We can't see you, so it's really nice to hear from you in some way or another. I'm curious to know, like, Ida, we don't know about what your background is. So do you have a lot of experience in program evaluation? What do you think are the benefits and challenges of using mixed methods for research? If you have any thoughts to share, please feel free. So is this going to be you, Zoe?
Yeah.
Great.
So when developing the CanQuit prototype, we developed a content library. We trained moderators to manage the Facebook group. We developed the closed hidden Facebook group itself. And then we beta tested the Facebook group with 10 Alaska Native people who smoke. So the content library that we developed included postings that included like still images, videos, and all of the postings included accompanying text with the post, and all of the text had a question to prompt conversation on the post. And our content library was organized by certain themes, like some of the posts revolved around family, some of the posts revolved around nature or the health benefits of quitting smoking. And it was in a format where the moderators could search through and find what content that they would like to post that day, depending on the category it fit into. And so we developed our content library using the qualitative interviews and the quantitative survey. The interviews were conducted with Alaska Native people who smoke and also tobacco cessation counselors or other providers that work in the tobacco cessation field. And we asked them to evaluate existing content that was developed by the CDC Tips from a Former Smoker. And we asked them to evaluate it on the meaning of the posts, the appeal, the fit with Alaska Native culture, and for perceived effectiveness. And we asked for recommendations on how we could improve these posts. And as we created the content library, we developed the posts in a format that the moderators could use to directly post into the Facebook group. And this is an example of one of the posts that we asked participants to give us feedback on. It is a post by the CDC Tips from a Former Smoker campaign. And these are the questions we asked in the interview. What message did you take away? What did you think of the picture and text? How do you make this post better? How does this fit with Alaska Native culture? And how do you think this post might be effective in motivating an Alaska Native person to use a quit line or tribal smoking cessation program? And for example, some of the feedback we received from this post is, oh, fishing fits in with Alaska Native culture, but we don't do that type of fishing here. It doesn't really look like us sitting on a dock fishing. And other comments were like, oh, if it was featured in Alaska with Alaska Native people, it would be much more culturally relevant. And so for the survey, we asked participants to evaluate, again, the already existing CDC Tips from a Former Smoker campaign content and videos on the story strength, the relevance to Alaska Native culture, emotional appeal, relatability to Alaska Native people, relevance to Alaska Native families, and which video was their favorite. And none of the postings were rated highly across all of the themes. And this is the perceived effectiveness measure that was used in the survey. And we asked everyone to rate it from strongly disagree to strongly agree. This was worth remembering. This grabbed my attention. This was powerful, informative, meaningful, convincing, and this fits with my culture. And our goal was to take the interviews and the survey or take the results from both the interview and the survey and make an informed selection and refinement of content to use in our Facebook group.
So I might also add, one of the things in the earlier slide was we found from the qualitative interviews that you conducted was that no piece of content that we asked people to give us feedback on was like deemed perfect. There were problems with all of the content. So what we wanted to do in the perceived effectiveness phase was select a variety of content, less content than we did in the first phase, but content that had different strengths and weaknesses. So we could evaluate their perceived effectiveness to determine what changes we needed to make or refinements we needed to make to the content before we put them into the library. I hope that's clear. It's not moving. There we go.
Okay, and so for the perceived effectiveness survey, all of the perceived effectiveness and culturally relevant scores fell between 3.5 and 4.4 out of a scale of 1 to 5. And the content that was rated to be the most appealing, effective, and culturally relevant was selected to be included in our content library. But we made refinements to the existing content developed by the CDC to incorporate images of Alaska Native people, also Alaska Native activities, but they were consistent with the CDC style presentation with a tagline, and every post had a link to quitting resources. To the left, this is an image of the high kick for the Native Youth Olympics featured here in Alaska. And we have the tagline, reach for your goals, not tobacco. And also on the bottom, you can see the link to the Alaska Tobacco Quit line. And based on the perceived effectiveness results, it indicated that we needed a wide variety of content to pull from. As I said previously, like we had posts that focused on family or nature or activities outside, and also health benefits. So we needed to create a large variety of different posts for the group. So our final content library contains 64 different posts, which include the images with accompanying text. And then we also included some videos. And the way we formed the content library, it was similar to a treatment manual, and in that you could search through it. We also did polls to evaluate our participants' values and what resonated with them the most. And we posted content based on their responses.
Okay, so now we have another something for you guys to look at. And I want you to think about we have before and after pictures. So you can see how we actually did refine the content. And so I just want to see if you see the changes that we made. So here's the first one. So on the left is a CDC tips from a former smoker post. And by the way, we collaborated with the CDC, so they were partners in this research as well. So we had permission to use their materials. So we have a woman here sitting on a couch in Florida. So we took the same tagline, quitting isn't about what you give up, it's about what you get back. And we adapted it for Alaska. And as you can see, we've got a grandpa with a baby. Family values are really important, family and community and babies and children as motivations for quitting smoking. And he's an Alaska Native man. So you can see how that might be more appealing if we're doing an intervention focused on Alaska Native people who smoke. Our tagline is a little bit different because we have 1-800-QUIT-NOW, but in addition, we have a link to tribal quitting resources that are available on every single post as well. Some people would prefer to use their tribal quitting resources in their own community rather than call the quit line, and both of them are available. And here's the next one. As you can see on the left is the CDC tips image, and on the right is the image for the Can Quit study. And again, we have an Alaska Native elder Alaska Native people respect their elders and listen to them. In the background, you can obviously see that he's in Alaska, has the same tagline, and it also has, similar to CDC tips, it has a link to the quitting resources. The picture on the right is a little bit less, I would say, shocking than the one on the left. That would be the primary difference. And in the interviews, we got feedback that people like stories without sugarcoating, and they like to hear it, but they didn't want us to go too far. So now I'm going to show you guys 2 videos. I wanted to give you an example to see what the CDC videos look like, and also what the ANTHC digital stories are like. So I'm going to have to stop my share and do a new share. And I'm a little bit new at this, so just bear with me.
Oh, and to answer your question, did you take your own pictures for the campaign, or were these publicly available? These were available through ANTHC's marketing department, and we got permission from them to use the photos.
All right, hold on a minute. I'm having some trouble getting the video. I'm going to stop the share. There we go. Okay.
And another question, did you monitor which media in general was most effective? I would say a majority of our posts were images, and because I think the prompts generated more response on the postings.
Okay, so I've got this up. Please let me know if we don't get sound.
My parents were smokers. Both smoked cigarettes as far as I could remember as a young child. Remembering our home filled at times with clouds of smoke, my brother, sister, and I ran around pretending to be planes flying through those clouds. Little did we know at that time how harmful this was to us and our parents. I ended up with asthma due to the effects of these clouds, and my dad with cancer. My dad was diagnosed with cancer in 1998 and had quit smoking for a year. One day he reached for a cigarette in his shirt pocket, but thought to himself, "Nah, I'll wait for a little bit." Each little bit of time became days, weeks, then months, and a year had passed. If only he had done this long ago. I chose to be tobacco-free. I love my son, my husband, my family, and my community. I love to be outdoors, camping, fishing, or picking berries. I enjoy riding my four-wheeler, and now a snow machine. I don't want to be slowed down by asthma. When I'm out and about, there are people who still smoke cigarettes where they're not supposed to, like the main entrances or exits. In my community or in the city, I'm still walking through clouds. Because of my asthma, cigarette smoke causes me to cough at times and does take a toll on me to settle down. My hope for my community is health, and the only clouds we go through are when we are passengers on an airplane.
Now, I'm going to start from here, but if there is an issue with sound again, please let me know.
I'm Bill. I've had diabetes since I was a little kid, and I used to smoke. That's a bad combination. But if you're doing that, I've got a tip for you. Make a list. Put the people you love at the top. Put down your eyes, your legs, your kidneys, and your heart. Now, cross off all the things you're okay with losing because you'd rather smoke. You can quit.
So you can see from those 2 videos, from the qualitative interviews, people responded to both of those videos. The first video was one of the favorite videos expressed by the participants in the study. The second one people really responded to because of the focus on the family and the drama of losing a leg, and because a lot of the participants had experience or knew of people who had diabetes. The Bill's video, however, they said they would prefer to see Alaska Native people, but they found his story compelling because it was told without sugarcoating. So we just wanted to give you a little example of that. So now I'm going to go back to the presentation. So here is just an example of a page from the content library. As you can see, all of the content is numbered, the image is available, and then there are a list of possible moderator responses that are already developed that a moderator can use or adapt for their purposes. One of the things that we really wanted to make possible is for moderators to be able to be flexible as to what's going on in the conversation in their group. They didn't want things to sound, robotic or canned. So moderators are a really important part of the prototype. So we have the content, and we talked about how we developed our content and evaluated it. The next important part is to talk about the moderators who are kind of leading the group. They're very critical. They can make or break the group's success. A moderator, you can think about like a host at a party. They're the people there to kind of direct engagement. They want to introduce participants to each other. They want to promote conversations. They want to make sure that if it's conversation around behavior change, that the conversation, their correct information is conveyed. Our moderators, and Zoe was one of our moderators, they were both Alaska Native, and they both work as tobacco counselors. In addition, they received training, and they also provided information back to the trainers to make sure that the training was relevant for Alaska Native people. In online community management, we had a woman, Colleen Young, who runs Mayo Clinic Connect, which is an online patient community run through the Mayo Clinic, who provided training on how to promote engagement and manage a community online. And then we also had Ken Resnickow, who is an expert from the University of Michigan in health behavior change, who provided training in lay motivational interviewing and health behavior change and communication strategies. So our challenge was to figure out how to create a community of talkers, not just readers. So this is the training plan. And so I got to move things around so I can see. The idea is to exchange expertise to enhance cultural competency, communication, and online community management skills, which I talked about, and enhance ability of moderators to build community and promote behavior change. For our purpose, the behavior change target was to get people to call the quit line or their tribal quitting resources to quit smoking. And the training that was provided was, part of it was didactic and some of it was virtual. And then a lot of it was hands-on scenario-based training, whereby the moderators had the opportunity to, we developed like a practice can quit site on Facebook, a practice group, where the moderators were given comments to respond to and posts to put out. And they had practice, and then they would get feedback from the trainers on, suggestions on how to improve their responses or what to focus on. So this just gives you an example of how to respond reflectively, how to elicit change talk. So it's like, sounds like you are moving toward giving up smoking. So you're showing the group participant that you hear what you've read what they've written. You understand what they're doing. You're repeating back to them what they're talking about. You're reflecting that back to them. And then you're providing reinforcement and then support for their efforts. So the next part of the prototype, after we've developed the content library, our moderators have gone through a training process. We have to actually set up the Facebook group. And quite honestly, this part is not so hard because Facebook makes it very easy to set up a group. It's kind of like a wizard. They prompt you You want to have your group name, you select cover photos, you have an about section, you have your group rules and guidelines, privacy settings. And then within our group, we had links to our quitting resources displayed on all of our content. It was pretty straightforward. So this is just an example of what our cover page looked like. Our about section. And you can see here in the about section, we have the link to the 1-800-QUIT-NOW, and then tribal quitting resources. Interestingly, the tribal quitting resources, there's a lot of them. There's like 50. So it's not simple like the 1-800-QUIT-NOW. So we had a woman involved in the study create a Google form. So people could click on one simple link and then they could find their specific tribal quitting resource easily. These are the basic group rules from the admins. And then now, as you can see, I had developed our whole prototype, the content library, moderators selected and trained, Facebook group set up. And just by the way, I think I forgot to mention this. This Facebook group was both closed and hidden. And what that means is that it's not searchable, it can't be found by other people. And the only people who are aware of what's going on the page or their activity is the people who are in the closed private group. And Zoe's going to talk to you about our final phase of development, which is of the prototype, which is the beta test.
Right. Yeah, so the beta test included 10 Alaska Native adults who smoke. It was up for 30 days. And this really gave an opportunity for myself as a moderator to practice what I learned and to also see what worked, what didn't work with the postings, how often we should post, what was helpful to improve engagement from participants before we did the pilot trial with 60 participants. And so,
sorry, Zoe.
oh, it's okay. And so for the beta test with 10 participants, we did a baseline survey. This included demographic information, smoking behavior, and readiness to quit information. And after the 30 days within the Facebook group, we did a 1-month follow-up survey, which evaluated readiness to quit attempts, if they used the tobacco cessation resources, and the ease of CanQuit group platform, like how it was working, was it easy to use, how could we improve it? And we used the social media usability scale, which was a 3-item measure that evaluated how easy it was to use, usefulness, and satisfaction. We provided participants a $25 gift card for each assessment they completed. And they also had an opportunity to provide feedback with open-ended questions. And so at the baseline survey, participants reported they smoked on average 10.2 cigarettes per day. 60% reported that they were ready to quit, and 50% reported readiness to use smoking cessation treatment. And at 1-month follow-up, 6 out of the 10 participants made a quit attempt, and 2 out of the 10 participants actually quit smoking. 50% reported high levels of readiness to quit, and 56% reported high levels of readiness to use cessation treatment. And so moderators posted 19 times in the 30-day period. We actually had one participant who created their own similar post with a picture of their children as their reason for quitting. Participants posted 35 reactions and 130 comments. 58% were from the moderators and 42% was from the participants. And the range of comments per person was between 1 and 24. We had participants that were commenting on every post and were really engaged. And then we had a few participants who commented once and were more like readers rather than participating as much. For the 2 people who reported that they quit smoking, one of them posted 15 comments and the other posted 2. And just wanted to mention that there were some challenges with getting the Facebook engagement data after the group ended, like pulling all of the comments and reactions from the Facebook group.
Yeah, I would just say that it's Facebook groups are very different from pages. And so the amount of statistics on user engagement that you get from a group is very different. And because this was a beta test and we had a small number of people, Facebook provides even less data. So it's just something to keep in mind that you need to be tracking your data yourself if you're going to be using a group with a small number of people. And then the other part is that Facebook sometimes removes your content. So there's a need to back up and keep track of what you're posting for evaluation purposes down the line.
And so participant feedback were to clarify the group's purpose, which is to promote tobacco cessation resources and help people quit smoking, to provide more incentives and games to make the group more engaging, to improve the posts, include more rural photos, less medical photos, and more interactive posts. And again, it want moderators to make the group more interactive. And we try to address that in the pilot study by including using like the poll function within Facebook and trying to find different ways to engage participants. And feedback from myself and the one other moderator is it was challenging to keep up with the posts. We would try to respond to participants within an hour, 7 days a week. So we were trying to keep up with, or it was difficult at times to keep up with participants' comments. We had to develop a spreadsheet to track participants, especially with 2 moderators. I like to keep track of the conversations we have with each participant, and also I'd be able to see, okay, my other moderator responded to this person, and this is the conversation they had. And we could build off of these conversations over the 30-day period. It was challenging to get members to interact. As I said, there are some people who are readers and some people who are super engaged, but it'd be great to get everyone to interact with the posts. And we also had instances where group members would share difficult personal experiences, and learning how to respond to some of these comments where people shared a lot. And there was also a member who shared some of the information outside of our group. I think what they did is they took a screenshot of our post and used it on their personal page to sell their small business items. So there were some issues around that. But overall, the motivational interviewing training that we went through was really helpful in helping to promote the tobacco cessation resources from an online platform. So in conclusion, the results from the beta test were encouraging that participants expressed that it was usable and it could potentially be effective. 2 out of the 10 participants used the quit line. And I think the national average was about like 1 in 10 US adults end up quitting smoking in comparison to 7 out of 10 US adults want to quit smoking. And so based on the feedback, we improved by increasing moderator training to help encourage like community and promote participants participating. and more training on how to address like some emotional conversations where participants are sharing personal information, and also adding more welcome posts to the group page to clarify what the group purpose is.
So now we're going to talk to you about the lessons that we've learned that we want to share with other people who are interested in developing their own social media interventions to promote behavior change. The first one would be the value in the use of mixed methods to evaluate content. I think Zoe would attest to the fact that while conducting those qualitative interviews was extremely time consuming. It takes a long time to schedule all the interviews, to actually conduct them, and then to analyze that data. Unlike quantitative data with qualitative, we have to do the analysis ourselves. We can't press a button and run it in ANOVA. So it takes time, but we get that really like specific, detailed content that we need. And then balancing it with the quantitative statistics, we found really helpful, because once we had a target of what we were trying to evaluate, then we could evaluate it more simply, more quantitatively. And that phase was the easiest phase to recruit for and the easiest phase to complete.
Another lesson was how important it is to select moderators who can relate to your group. Because it was a group for Alaska Native people, I thought it was very fitting that I'm Alaska Native and the other moderator was Alaska Native. I think we could relate to the group members more, and that group members were more willing to engage and participate in the group because they could relate to us and felt comfortable sharing.
And I would say it was the exact same too, because Zoe did the qualitative interviews. I do not think that the in-depth information that we got from the interviews would have been as valuable if it hadn't been conducted by Zoe. The other lesson that we learned is to build upon existing skills of your moderators. So both of our moderators were Alaska Native. They understand Alaska Native culture, but they're also we're both tobacco cessation counselors. So they understand what the issues are in smoking cessation. So that made them very valuable as moderators.
Build community engagement. I would say this was probably the most challenging part of the Facebook group for myself as a moderator. We did start to tag participants to respond to some of the posts and try to engage participants that way. We also realized posting every day was, I'm not sure if it was like overwhelming, but we realized that people commented less when we were posting so frequently. So we'd post every 2 to 3 days.
Use existing resources for content and then adapt it for cultural fit. There's a lot of great content out on the web, as you guys are all aware of. And why not take advantage of it? And using those digital stories that took a lot of time to develop, and using those CDC tips videos, which have been heavily evaluated, really gave us a leg up and made the study more feasible and cost effective, and gave us really quality content to work with.
Design content that highlights your goals. So all of our content was around providing tobacco cessation resources, but just making it clear that our group is to provide these resources and to provide social support to help them quit smoking.
So the next tip is to include a wide variety of content in a searchable library format. So I think we've discussed this a lot, but it was very already. We have the content library that shows up on the Facebook group, but we had a fully developed content library before we ever started the group. And you really need to make sure you have your content library well prepared and evaluated before you start your group.
Balance content with conversation. This kind of goes back to where we decided not to post every day because we were receiving less comments and less engagement that way. And so knowing how often to post based on the group and encouraging the conversation on the posts that you do end up posting.
And we've discussed this already. So support your moderators to handle emotional posts. We had a full research team. We had clinical psychologists on the research team. We had experts in motivational interviewing and communication. And we used these team members and they consulted with our moderators when they needed help and were available. So that's important.
And number 10, groom group participants to be moderators. As I mentioned, that it was pretty challenging for myself and the other moderator to keep up with the Facebook group and make sure that we responded to all the posts in a timely manner. And we did have participants that were really engaged with the Facebook group, and they started to comment to other participants and started responding, and they started being moderators themselves.
And our final lesson learned is make sure it's fun. You need to build in the fun, take advantage of whatever platform you're working on. Facebook has polls, Facebook has Facebook Live that we could do. It was even suggested by someone in the beta test that we do a Facebook Live event. Figure out ways to engage people, maybe do some drawings and incentive prizes. Not everything has to be 100% directed to the health behavior change. We've got to build in some things because we're building a community. So we want to make sure that we lighten things up a bit at times. So our next step is the pilot RCT, which we have conducted, but we're running up the results now. We're not allowed to share those yet. We have to get approval, tribal approval, before we're allowed to share those results. So that's the next step. We also received supplemental NIH funding to add COVID-19 related assessments to our study because our pilot study was took place all during the pandemic. And then we will be presenting the trial results to our advisory board at ANTHC to determine the next steps for the intervention. Depending upon the results, I guess we'll decide whether we'll have another larger scale run of Can Quit. And then here I just have links and references to papers that have been published about our study. The one that is most relevant to the presentation you watched today is the one on content library development, if you are interested. So I'm going to stop sharing now, and then I want to make sure I didn't miss any questions. I think I saw something in the Q&A. Someone wanted to know about, was it consent? How did you manage the issue of consent? So we had Facebook ads. If somebody was interested, we screened them for eligibility over the phone. We have actually a study phone. It's a cell phone with a phone number from Alaska. And if they met the eligibility and we would consent them, we gave them the information on the study verbally, and then we either faxed or emailed them a consent form and they had to send it back in order to participate. So they would know about all the benefits and risks of participation, as well as the remuneration provided. Were there any other questions, Eric, that we've missed?
I don't think so. If anybody has any final questions, please type them in to either the chat or the Q&A. I was just thinking about this. I mean, I think it's really fascinating when you post something and then people start posting back and they start engaging each other, kind of like, you know, could you do something where it's kind of like the trainer model where you have all this information and then you kind of recruit some of these peers to then go out maybe into other groups. And I don't know if Facebook is a place where that could happen, but I'm also thinking about other social media sites. Like I know Reddit has a lot of interaction and groups, but I'm not sure about some other social media sites.
Yeah, that's a great point. For the beta test, was hard to get some of that going. It was more to kind of work out bugs because we only had 10 participants. And so in the RCT, the pilot RCT, it was 30 participants, and it was also over, 3 to 6 months versus the 1 month. So where you can really see where people can really start building engagement with each other and not just with their moderator.
Sure. I mean, I also think it's interesting. I would, Zoe, I was thinking about, gosh, before you presented the results, it's like, God, you must have been like on this, late at night, responding to people, and like, how do you balance that? But then, you figured out that actually, posting too much maybe was overwhelming, and it just didn't get as many hits. So I guess it's trying to find that balance.
Yeah, it was definitely a learning process, but we got used to it over time, responding late at night, checking it first thing in the morning.
Yeah, you just have to have a really agreeable or flexible staff member that's going to help do that. And plus, I guess it's easier with it on your phone now too. You could just do it, I guess, laying in bed if you really needed to, but still, it's a lot. But this is really great. Does anybody have any final questions before we break? I don't see any more questions. But if any, we'll post up your contact information if anybody has any questions after the fact. We also have a survey link in the chat that Karen just posted here. So please click on that. You can give us some feedback there. You can also request some questions there that we can send to our presenters today. But yeah, I just want to say thank you so much to you both for presenting today. I think this is really informative. We are very excited to see what happens with the rest of the study, and wish you both the best. So thank you so much.
Thank you.
Great, thank you.